of this whole presentation, a careful history and examination is the most important aspect of it. Musculoskeletal problems can sometimes be the initial presentation of non-rheumatologic diseases such as malignancies and infections. And in many cases, the initial diagnosis of rheumatologic diseases may not lead to a final diagnosis in 50% of cases. And a lot of the different associations like the American College of Rheumatology and EULA have criteria that can be used to make these diagnoses, but remember most of these were used more for assistance with research studies, and so sometimes they may not apply to the patient, that the patient may not fit all the criteria but can still have the illness. The CDC predicts by 2040 there'll be an estimated of about 78 million US adults, which is about 26% of the population having arthritis diagnosed by a doctor. And this is a leading, one of the leading causes of disability in the US. I would like to make note that we don't have a lot of data on the Caribbean system with Caribbean Research for Epidemiology. Sorry, are you guys hearing me? Because I know I lost the mic. Okay, perfect. So our objectives today is recognizing symptoms and examination findings that are indicative of rheumatic disease, the importance of early diagnosis and referral for treatment of these arthritis conditions, recognizing the role of the multidisciplinary team, in particular our health professionals, our general practitioners, internists, and other subspecialties, and to review the basic concepts of investigations used to diagnose these illnesses. So I want you to remember that joint pain can occur from the structure within. It can be adjacent to the joint or from distant sites, from other joints like the hip joint or the ankle joint if the patient's complaining of knee, tendons, and ligaments. And when patients complain about joint pain, remember it can come from the joint capsule, it can be from the periosteal bone, the tendon, the ligaments, or periarticular structures. When a patient presents, the history and examination is most important, and the type and pattern of arthritis is important. So are they describing an inflammatory or non-inflammatory component or periarticular? And I'll describe what this means in another slide. Are they complaining of one joint, which is known as monoarthritis, or oligoarthritis, which is less than 5 joints, or polyarticular, which is more than 5? And from investigations, do they have positive labs or negative labs? And then we go on to talk about lab investigations that can be done, synovial fluid analysis, imaging, and then treatment and referral. When we're taking the history, it's important to note the age, sex, and ethnicity because certain illnesses will be more prominent or present in younger ages versus older ages, female versus male, as we know a lot of the autoimmune illnesses affect female sex over male. And ethnicities, as some things are more predominant in the African population versus East Indian or Caucasian. And the characteristics of the joint pains are important. Did they start acutely, less than 6 weeks, or has it been going on for more than 6 weeks? Are they migratory? Are they progressive? Are they intermittent in nature? We discussed, are they affecting one joint, less than 5 joints, or more than 5 joints? Are they symmetrical or asymmetrical? And what kind of joints they involve? The small or large joints, back pains, and the nature of the joint pain, inflammatory versus non-inflammatory. So what is the definition of inflammatory joint pain? Usually the patient will complain of morning stiffness for more than 30 to 60 minutes, and pain presents with rest and activity. They may have joint swelling and inflammation in their surrounding areas. They may complain of nighttime pain, and they may have additional systemic symptoms, and the presentation can either be acute or subacute in nature. Non-inflammatory joint pains like your osteoarthritis, the morning stiffness is usually brief, lasting less than 30 minutes. They usually would note pain at the end of the day or after use. They can be swelling and can be bony formation, but not always. And nighttime pain is not usual, and they generally do not have systemic symptoms, and their symptoms tend to be chronic in nature. And periarticular, meaning like your bursitis and tendon, ligament, other issues, they may have stiffness in the morning, pain with activity, true joint swelling would be absent, they may have fatigue in the evening, and generally no systemic symptoms. Sorry. So in the history, other things that would be important to ask would be if they had any trauma or inciting events. Are they noticing any functional loss or disability? Do they have any family history of autoimmune or connective tissue diseases? And then, is there any evidence of systemic process or extra-articular features? The review of systems is important, and I didn't go into detail of review of systems, but things to note is that there are articular and non-articular manifestations, and depending on the illness, such as rheumatoid arthritis, they may complain of breathing issues, coughing, chest pain. These can all still be pertinent to the history. So it's important to ask a detailed history of review of systems, and the future presentations that we're having today will address those particular to the illnesses. Red flag signs, these are things that we should note and very important if the patient is noting significant weight loss, fevers or other systemic manifestations, nighttime pain, which may be significant for like malignancies or other inflammatory pains, a single joint involvement, because we would have to make sure that we have to rule out like a septic joint, and other neurological symptoms and signs. In the past medical history, things that may be pertinent for autoimmune illness are things like infections, fevers, weight loss, exposure to TB, miscarriages, and history of DVTs and Ps, which are more common in some autoimmune illnesses. Some medications may be implicated in the presenting complaint, such as statins that can cause muscle pains. Social history, again, also their sexual history is very important. Remember that if you have a swollen knee joint, it may be a gonococcal infection in a young gentleman. Occupational and environmental exposures and exposures to tick and mosquitoes are also very important to note. So when we look at a patient as they come into our room, some of the things that we can note in a patient who's in pain, you may notice from their face that they're grimacing, you may notice that they're limping. These may be signs that they're losing some of their functionality or that they have an underlying arthritis conditions. And when shaking the hands of patients who have joint pains in their hands, note that they may also note pain, so be very gentle in squeezing their hands. Some of the head and neck manifestations, you may notice redness of the eyes, you may notice that they may have blepharitis around the eyes, which is a swollen eyelid. They may note dry mouth, dry eyes. You may notice that their thyroid may be enlarged, or even some of their lymph nodes or their parotid glands. These are things that to look for. And then in rashes, we may note like a discoid lupus rash. You may notice patches. You may have to look under wigs if patients are wearing wigs, or if they have thick hair, just be sure to do a thorough scalp examination. This is the typical malar rash, a butterfly rash of a patient with lupus, but just remember that a lot of patients don't always present with this typical complaint, and you may have to look for smaller lesions like petechiae or the legs, or purpura, which are bigger lesions. And in the skin, the hand tells us a lot. From medical school, we remember that clubbing may be a sign, but Raynaud's may be a sign that you may notice that may be exacerbated by environmental or exposures to stress or cold. You may notice digital ulcers, you may notice redness or erythema around the eyelids, which may be significant for patients with dermatomyositis. The Scholl sign, where they would notice some erythema or darkening around their chest area. And this is a patient with livedo reticularis. So these are just to highlight some of the clinical features you may note in your examination. We get down to the hand, and I appreciate that for many people who don't have experience that this may be difficult for us to tell. If there's swelling, but this just takes experience and practice. And this is something definitive that you can see that there's swelling or synovitis, there's bulbous appearance here. Nodules or nodes in the distal interphalangeal joints, which you can see, Heberdin's nodes, sorry for the misspelling. And then you may notice tightening of the skin that we can see with sclerodactyly. In patients with gout, you can notice tophi at their distal interphalangeal joints. So, where it presents is very important for patients to understand. Osteoarthritis in the hands tends to affect the distal joints and the proximal interphalangeal joints, where rheumatoid tends to affect your metacarpal phalangeal joints and your proximal interphalangeal joints. And then crystalline arthropathy, such as your CPP disease, could present with your metacarpal phalangeal joints in your hands. Similarly, OA and RA affecting the knees will affect different distributions, as you can note here, where rheumatoid tends to affect the entire joint, where OA may affect more the patellar region. So the distribution of where the joint is noted, and even in X-ray findings, may be different for these patients. Nails also tell us a lot about a patient. Could anybody tell me what a possible diagnosis for this patient may be? Psoriasis, yeah, so you can see pitting of the nails, you can see dystrophic nails. This side is called oil drop nails. We can also look for clubbing, which may be features of some chronic illnesses. And then this is an easy test that can be done at the bedside using either an ophthalmoscope, but it's looking for dilated capillary loops, which we see in patients with Raynaud's and scleroderma. So the next step usually for a productive musculoskeletal exam is just doing the range of motion. And generally we would ask the patient to do the examination first. So that's called active range of motion. And this tests the joint and the contractile structure. Then generally the clinician will then go on to the passive movement. And then resisted movements may be used to essentially isolate if they're tendinitis or bursitis. This is an easy way of approaching the musculoskeletal screening, which I think is an easy way of, if you're seeing a patient with joint pains, you don't have a lot of time, just things that you may observe that may be helpful to consider before referring on to a rheumatologist. Observing their gait, observing their movements in their hands, going through their back palms, their grip, just squeezing their MCPs, which is called the squeeze test. Looking at their legs to see if they have good range of motion with flexion, extension, rotation of the hips, and then the spine movement also. Where it happens and the pattern is very important, and I think, as we mentioned earlier, if there's one joint involved, you may consider infection, gout, tumors, but if there are multiple joints, this may be a sign that the patient has osteoarthritis, spondyloarthropathy, gout, or atypical RE. RE in general, though, presents as more of a symmetrical polyarticular pattern. And then when considering back pains also, always consider inflammatory symptoms. Examine the SI joints, because these may be signs of ankylosing spondylitis or one of the other spondyloarthropathies. If the hand distal interphalangeal joints involved, you may be thinking of gout, OA, or psoriatic arthritis. Hand proximal interphalangeal joints, which are these joints, you may be thinking of OA and RA. And if the MCP joints, as we noted earlier, you may be considering RA or CPPD. And then the first MTP joint, gout or podagra versus OA, which can affect the first MTP joint in older patients, and then reactive arthritis. So I think this is probably going to be the most important segment, is how do we interpret these investigations and why do we do labs? Remember that when I started the presentation, I noted that history and examination is the key part. Most diagnosis in rheumatology should be made by a history and examination. But labs are there to help confirm what we suspect and to kind of monitor the prognosis and the disease activity. And we sometimes follow certain labs to see the response to therapy. What are some of the labs we may order? We ask that we don't just do a pan ordering, and a lot of times in the Caribbean countries, because labs are expensive or unavailable, we're not allowed to order multiple investigations. But some of the basics ones you should consider are your blood count, liver, urine, ESR, and CRP. But if suspecting rheumatoid and rheumatoid arthritis, you can order rheumatoid factor and CCP antibody. If you are suspecting lupus, you may order the ANA antibodies or the further antibody panels. So, an ESR. What is an ESR? It essentially is produced as a response to inflammatory process where there's essentially release of interleukin-1s, interleukin-6, interferon gamma, and this increases the liver synthesis of these plasma proteins. And these can increase up to 25% during states of inflammation. And what happens is the red blood cells interact with these proteins. They form clusters that sediment faster than the usual rate of the red blood cells. And when these are anticoagulated, then essentially they leave it to stand for about an hour, and the measurement is usually from the top of the tube to where the sediment is measured, and that's measured in millimeters per hour. But note that depending on where you do it, it's very sensitive to handling and warmer temperatures and temperature changes. ESRs are usually measured by age over 2 for males, and females age plus 10 over 2. And the normalization of the ESR can lag behind the resolution of the inflammation. And they can be high not only in rheumatic diseases, but infections, malignancy, and trauma. And anything that affects the red blood cell count can affect your ESR. So you can note that most of the things listed here show things that reflect the red blood cell count, your anemia, sickle cell disease. CRPs are also acute phase proteins are synthesized in response to the tissue injury. These usually increase within 6 to 10 hours and decrease within 1 week. There's less variability with age, but a normal or indeterminate level does not exclude the presence of inflammation because there's a certain degree of damage that has to be done to be able to cause this inflammation. And you may see these elevated again in rheumatic illnesses, but other chronic illnesses. And remember, obese patients, smoking patients, and African patients tend to have a higher CRP. Rheumatoid factors, they bind to the region, the Fc region of the human immunoglobulin, and there are different fixation processes, but in the interest of time, I'm going to skip this slide. Just to note that the sensitivity rate is very low at 26 to 90%, but the specificity is 80 to 95%. And they tend to have a lower sensitivity in the early rheumatoid diagnosis, but the rheumatoid factor can be present up to 5 years before diagnosis. Higher rheumatoid factors in patients with rheumatoid arthritis represent more severe disease and worse prognosis. But I want you to note that rheumatoid factors can be elevated in elderly populations, so as we age, and in other chronic illnesses, including infections such as hepatitis C. So the next test that we have here is your anti-citrullinated peptide antibody, also known as CCP antibody. And this has a higher specificity for diagnosis of rheumatoid arthritis, but the presence of it usually represents more aggressive disease in rheumatoid arthritis. ANA antibodies are usually measured to screen for connective tissue diseases, and in particular in lupus. And I want you to note that a lot of times we'll get referrals for low ANA antibodies. There's a lower likelihood of autoimmune illnesses. You really want to consider when the titers are higher with existing clinical picture that there's an increased suspicion for connective tissue diseases. And the staining and pattern is important for helping us differentiate what connective tissue disease may be involved. So just going through this, ANAs can be positive in multiple illnesses: lupus, mixed connective tissue disease, RA, polymyositis, in autoimmune liver disease, malignancy, thyroid disease, but remember, in 5 to 10% of the normal population and in the elderly population, it can also be positive. And the specific antibodies that are present may represent the different illnesses. And again, we can, now with access to Google, we can Google these, so I'm not going to go through these in detail because of interest of time. We may need to aspirate a joint if there is a monoarticular joint pain or we don't have a diagnosis. It's important to consider this with a patient who presents with an acute joint swelling to rule out septic arthritis, as this can be life-threatening and also can lead to erosions of the joints. And when aspirated, we usually send the fluid off for cell count with diff, Brafstein and culture, and crystalline analysis. This is just a breakdown of when you do the aspiration, what the different, if you have elevated white cell counts, what represents in terms of inflammatory versus non-inflammatory in a septic joint. X-rays can be useful in viewing to monitor disease progression and monitor for tissue, bone swelling, erosions, and crystalline disease. But we also use other imaging and rheumatology nowadays to help with our diagnosis. And these were some pictures that I had here to highlight that you may see in your clinic and your offices where you may see erosions in the joints. This usually means that the patient has had disease for a while or it's more aggressive, and this should warrant a referral to a rheumatologist. Plain X-rays can also be used to diagnose and confirm osteoarthritis. Always remember, if you're ordering a knee X-ray, to do a weight-bearing knee X-ray to help assist with the diagnosis. This shows erosions and loss of joint space and osteophyte formation in a patient with osteoarthritis of their distal interphalangeal joints. And these show punched out lesions in a patient with gout. And this reflects here to fascia skull, where you can see this opacity here. We're now using musculoskeletal ultrasound more to help with diagnosis. Because of the expense and the time that it takes in clinic, it isn't always used in a daily rheumatology clinic now, but it can be very helpful. So our goals of treatment should be to relieve pain, to prevent joint damage and erosions, to preserve functionality and prevent disability in our patients, and to prevent secondary sequelae of these patients. And there will be both pharmacological and non-pharmacological intervention. And a lot of our general practitioners can help us with the early initiation of some of the pharmacological medications. But we ask that that patients just don't be maintained on NSAIDs, that you do consider if they have a diagnosis of RA or some other systemic illness, that we should refer on to consider some of our DMARD therapy or in cases that are necessary, biologics or other immunomodulators. And noting the importance of non-pharmacological interventions such as physical therapy, podiatry referrals, occupational therapy, patient education and support groups. The importance of the early referral is for diagnosis and treatment to achieve optimal control of disease and prevent progression, for diagnostic and uncertainty and confirmation of the illness, to help with managing conditions that are not responding to conventional treatment measures, and to consider for other treatment options such as orthopedics and podiatry. And the ACR recommends that early referral for patients with unclear diagnosis, fevers that are not diagnosed, patients with normal lab studies but local or generalized joint pains or swelling, abnormal lab findings that do not make sense in a clinical picture, unexplained musculoskeletal pain, and unexplained constellation of symptoms including fatigue, rash, fevers, arthritis, anemia, weakness, or weight loss. We appreciate the help of our general practitioners, and in the Caribbean where there are limited rheumatologists, we ask that you consider early referral or at least touching base with a rheumatologist if needed assistance to help prevent mortality and morbidity and the sequelae related to it. Thank you.
For that kind introduction, and I'd like to thank Fernando for inviting me to speak with you. You're hearing me clearly? No, that's what I thought. Are you hearing me now? Okay, great. I'd also like to thank Linda for that great presentation that she gave. And in fact, there's a lot of overlap with what I have prepared. So you're going to see that I'm going to skip through a few slides just in the interest of time. If anybody needs to review anything, you can stop me. But as I said, just in the interest of time, you may see me flip over a few slides. In the next few minutes, however, we're going to try and look at rheumatoid arthritis. How do we approach our patients with rheumatoid arthritis? And we're going to highlight the fundamental changes in the approach to rheumatoid arthritis, review the clinical features of the illness, outline the evaluation of the patient to make a diagnosis, review treatment options and guidelines, review disease activity measures, and along the way we'll comment on some of the peculiarities of our region. So rheumatoid arthritis, as I'm sure we all know, is a chronic systemic autoimmune illness. It's the most common inflammatory arthritis that we will see day to day in clinical practice. And it's characterized by persistent synovitis leading to cartilage damage, joint deformity, bone erosions, and disability. In order to prevent all of those sequelae from the disease, we've had to undergo a very significant paradigm shift in rheumatology. And there are two constructs or two concepts that have helped to facilitate this change. One is the window of opportunity, which refers to early intervention, and the second is treat to target, where we now have a definite goal of remission for our patients. And a lot of this has been fueled by the advent of biologics, because now we knew we had drugs that could offer much more better therapy to patients. However, in our region, there's some difficulty with accessibility of these drugs. And also the other thing that has helped us to improve on our outcomes is the fact that we've been able to identify prognostic markers that help to categorize our patients and help us to know which ones require more aggressive treatment. So if we look a little bit more at the window of opportunity, the whole basis of this is that we understand that in patients with established disease where joint damage has already occurred, treatment is less effective than in patients with early disease. And when we talk about early disease, the period that we're referring to is in the first 12 weeks of disease. The window of opportunity is based on recognizing disease early, during which treatments may abolish symptoms and prevent or limit functional loss, joint deformities, and therefore long-term disability, reducing long-term care costs and improving the quality of life of our patients. Treat to Target, to some extent, facilitates this. It relies on tight clinical control using disease activity-guided treatment measures and strategies to aid in making therapy adjustments which are associated with higher rates of remission. And aggregation of inflammation is how we achieve these goals. The primary goal is to maximize long-term health-related quality of life through control of symptoms and prevention of damage, and keeping our patients functional and being able to participate in usual activities. The treatment must be based on a shared decision between the practitioner. I have rheumatologists here, but of course we know for some of us, we rely on non-rheumatologists to offer this care. So it must be a shared decision between the practitioner and the patient for it to be successful. There are some recommendations that were offered to us by an international task force in 2010, and I'm going to highlight a few of these things just for clarity. One is that when we refer to clinical remission, we're referring to the absence of signs and symptoms of significant inflammatory disease activity. And while remission is the clear target we should have for each of our patients, we recognize that low disease activity may be an acceptable alternative, especially in persons with established disease. As we stated before, they tend not to respond as robustly. And low disease activity, very often, it can be gauged in various ways, and we'll talk about that later. Until the desired treatment target is reached, drug therapy should be adjusted at least every 3 months. So in other words, this is a work in progress. You need to change if you haven't achieved the goal and continue until the goal is met. And thereafter, when remission is met, you need to maintain the patient in remission. The use of validated composite measures of disease activity, which include joint assessments, is needed in routine clinical practice to guide treatment decisions. And we'll briefly go through those at the end. Structural changes and functional impairments should be considered when making clinical decisions in addition to assessing composite measures. So in other words, apart from the composite measures, your clinical acumen still remains an important part of your management. So who are these patients we're talking about when we refer to our rheumatoid arthritis patients? The illness is seen most commonly in persons in the age group 30 to 50, but as we know, it can occur in the pediatric age group up until any age. Women are affected 3 times more commonly than men, and the worldwide prevalence is believed to be 1%. In our discussions during the conference, however, it seems that many islands see lower numbers of patients. My guesstimate would be that Jamaica would be close to the 1% mark, however. And how do these patients get the illness? As with most autoimmune illnesses, we don't fully understand, but we realize it's a very complex interplay of various mechanisms. We know for sure you have to have susceptibility genes, and HLA-DR4 and DR1 have been identified for rheumatoid arthritis. And at some point, there's an interaction with some environmental exposure or factor. Very commonly, it can be something as simple as an infection. And we have clear associations with smoking, with gum disease, with the gut microbiome. There are papers on lung disease, and even just stressors on the body can help with the precipitation of illness in patients. This pictorial basically just reinforces what we spoke about, but I just wanted to focus on the center column about midway there where we have self-protein citrullinations, because I think it's an important concept for us to understand. Linda had already pointed out to us the CCP test, anticyclic citrullinated peptide, and apart from being an important diagnostic marker, it's an important part of the whole pathogenesis of rheumatoid, because it represents an example of post-transcriptional modification in the person's or the patient's system or body, in which arginine, which is a typical amino acid, which is found in our protein structure, is substituted by citrulline. And citrulline is not typically found in mammalian protein. This is done by a process of deamination. And when this occurs, what happens is that the body now sees the person's protein as foreign. And this is what leads to that loss of tolerance and then the recruitment of an immune response. So we now understand this as one mechanism, and we've been able to also use it in our diagnostics, which is beautiful. There are many other things that happen, but time won't permit us today. So how do these patients present? Well, they present with an inflammatory arthritis. And as Linda has told us, these are patients who have significant morning stiffness lasting 30 minutes or more. Their pain tends to be worse in the mornings and relieved with activity. And your physical exam would include features of synovitis. So you would look for swelling. You would elicit joint tenderness. We have squeeze tests, which are simple tests, just simply going along the row of the MCPs and squeezing the row of the MTPs can elicit tenderness and also be an indication of inflammation being present. In more advanced cases or with severe pain, you may have reduced range of motion, and also you may find that there are obvious deformities present. How do you distinguish rheumatoid arthritis, though, from another inflammatory arthritis? Well, the distribution of the joints can be helpful. Rheumatoid arthritis very often affects the upper extremity, as in the small joints of the hands, the MCPs and the PIPs, along with the wrists, more so than it does the medium-sized joints, even though they can be affected, and the feet. Always remember to pay attention to neck pain in your rheumatoid patient, because we do have to worry about atlantoaxial instability, and if that's the case, get an X-ray. If you have a patient, however, that reports thoracolumbar or DIP involvement, think of another diagnosis, because those joint areas are spared in rheumatoid arthritis. Also remember that these patients present with systemic features. They may have fatigue, fever, anorexia, weight loss. I put this here just to reinforce once again that we should be capturing these patients at an early stage. The photo on the left and the image on the left shows early disease. You can see some subtle synovitis in the PIPs, especially the third PIP. And if you look at the X-ray, we see some mild periarticular osteopenia. Right here, we see some mild periarticular osteopenia in the MCP row, and some joint space narrowing. What we don't want to see is the picture on the right, where we have destruction of the joints. We have a Z deformity, we have ulnar deviation, we have prominence of MCPs right here because of subluxation. We have nodulosis right here. And then we have X-rays that go along showing erosive disease. I hope you can see it. The C, label C. And just somebody who is now pretty much disabled. These I put here, the top image is to show you Boutonniere's deformities, and the lower one in the fourth finger shows our typical swan neck deformity. I put this here because sometimes there are very simple diagnostic clues that are available to us, but if we don't know what we're looking for, sometimes we'll miss them. And Dr. Raj is kind enough to have this image on his room tutor. And it basically reminds us that in the feet, if you see splaying of the toes, that in of itself can be an idea or an indicator that there may be underlying inflammation at the MTPs. So we said that this is a systemic or multi-system disease. So in addition to joints, we have to remember that these patients may present with other features. And some of the extra-articular manifestations include nodulosis that we see less often now that we have better therapies. And once again, it was very interesting to hear the other Caribbean islands say that they don't see nodulosis, because we definitely still see it in Jamaica. Eye involvement is also quite common. Dry eyes, episcleritis, scleritis. Pulmonary disease, also fairly commonly seen extra-articular manifestation. There may be pleurisy, where there is inflammation of the lining of the lung and the heart. You may have interstitial lung disease, and rarely, I think, rheumatoid nodules. In the hematologic system, these patients have a normocytic normochromic anemia, and they may have leukocytosis, leukopenia, and thrombocytosis. Neurologic system, we think of entrapment neuropathies such as carpal tunnel syndrome. Vasculitis, I don't think we see that commonly anymore either with better therapies. So how do we investigate these patients? Well, as we said before, your CBC can reveal certain changes. and the thrombocytosis and the leukocytosis can be an indication of systemic inflammation, even with normal inflammatory markers. We recommend a baseline renal and liver function because these can be used to help monitor safety if patients are being placed on DMARD therapy. ESR and CRP, non-specific but also reflect systemic inflammation and are useful to map or monitor how the patient responds to therapy. Rheumatoid factor and CCP are two serologies, as Linda has indicated, and then you would tailor the remainder of your investigations based off of the clinical picture of the patient. Because as Linda has stated, we don't want a wide net. We want to be able to base our investigations as to what is happening to that specific patient. Viral serologies can be very important though. Viral hepatitis in and of itself can cause inflammatory arthritis. And we know that we should check hepatitis B if we are going to start any immunosuppressive therapy. TSH, vitamin D levels may be important, comorbid features. ANA, check because lupus is quite common in our area. Do a protein electrophoresis, especially in children, somebody who just doesn't fit the full picture, because we know one of our differentials is a whole myeloma or lymphoproliferative diseases. And MAN2 testing or TB screening important, especially if we're going on to biologic therapy. A very important fact to remember is that normal serologies do not exclude the diagnosis of rheumatoid. And upwards of maybe 30% of patients, especially in early disease, may present with negative markers. Some will seroconvert along the way and some will stay negative. But if you still have the diagnosis in your head, do not throw it away because the serologies are negative. So Linda did a great job at going through this. I'm not going to spend much time. Just remember also, rheumatoid factor is seen in a number of other illnesses. So if you have a positive rheumatoid factor, do not jump on it that the diagnosis is rheumatoid arthritis. The CCP offers a little bit more specificity, but still, we're realizing that it is seen in other conditions, but also both markers help us with prognosis of the disease. We know patients who have negative markers tend to have, or we assume will have a milder course. Persons with positive markers will be more at risk for radiographic progression, disease severity, and poor functional outcomes. Imaging in rheumatoid arthritis, early on we see soft tissue swelling, symmetric joint space narrowing, periarticular osteopenia, and as we go on with the disease, within the first year or two, you can start to have erosive disease and joint destruction. MRI usually for difficult cases, and bedside ultrasound, very useful, both diagnostically and therapeutically, but I think the challenge in our region from exposure and fellowship was that the cost is a bit prohibitive for our patients. I'm going to skip over this. So this is our correct 2010 EULAR ACR criteria, and what it really does is extract the most pertinent features, clinical features. We know that this is a polyarticular disease, and we know that small joints are predominantly what's affected, so the scoring is based on how many joints and which joints are affected. Serologies also give a score, and the higher the serology titer is, the more clinically significant it is believed to be, and so you get a higher score. It is a chronic disease, so you get a score for having disease for more than 6 weeks, and also evidence of systemic inflammation gives you a score. We can tell a patient that they have definite RA if they score 6 or greater. And what's interesting is that it allows us, because of the complexity of these diseases, to both go over time and monitor and map the patient and accumulate the score. So you don't have to make the diagnosis the first time you see the patient. And also you can look retrospectively and add up various points that will make you come to a diagnosis. In other words, you're not expected necessarily to make the diagnosis at one visit. Poor prognostic markers, high titers, radiographic changes earlier at presentation, the shared epitope, and smoking. So if you have patients who smoke, you have to let them know that's something that they have to give up. Our approach to management. We've said this before. Early treatment, remission is the goal. Close monitoring is how to get there. How well are we doing this? I know in the Jamaican context, not so well. Even though we've managed to move from 1 rheumatologist to 6, we still, for a population of 2.8 to 3 million persons, have about a rough, estimate of 500,000 persons per rheumatologist, and therefore we have quite long wait periods. So if we're saying we want to see persons within, the first 12 weeks, sometimes the wait periods are almost 12 weeks, especially in the public sector. So we have a lot of work to do, but we're trying our best. The approach to management, you must educate patients and practitioners, utilize your drug therapies to the best of your ability, whatever is available to you. We have treatment guidelines that I'll briefly just show. We know that some of these things are not available in certain territories, but you do the best you can for your patients. Lifestyle changes, smoking cessation, as we said before, diet, exercise, sleep. You make use of allied health workers, your physiotherapists, your occupational therapists. Make sure that your patients get their appropriate vaccinations. We have them on drugs that can cause other comorbidities. Make sure they have their osteoporosis and GI prophylaxis on board. NSAIDs continue to be used upfront to bring some measure of relief, but bear in mind they don't alter the course of disease. You have to go to steroids and DMARD therapy to get immune modulation. Steroids, however, we use as bridge therapy and also for acute flares. And by bridge therapy, I mean that basically when we're initiating therapy, our DMARD drugs are slow acting, and therefore, to give some relief and to help to quiet the immune response, we use steroids early on until our more definitive long-term therapies have kicked in. And it means therefore that DMARDs and immunosuppressive drugs must be instituted once the diagnosis is made. There are a number of drugs available to us in our class of DMARDs. We could look at methotrexate or think of it as the anchor drug, but in truth and in fact, hydroxychloroquine does quite well in a number of our patients who have mild disease. Other DMARDs available are leflunomide, sulfasalazine, azathioprine. Xeljanz is not available in Jamaica, but I realize in other territories like Dominican Republic, it is there, and it's approved to be used after methotrexate failure. Our biologics, as we said before, are the drugs that have really changed and improved our remission rates. TNF inhibitors, of which we have adalimumab, infliximab, etanercept, golimumab, certolizumab, IL-6, tocilizumab, and anakinra, used mainly in the pediatric group. And then we have other mechanisms of action. We have rituximab that works on B cells, and abatacept, a T cell co-stimulator inhibitor. This has been provided to us by ACR, and it's really an algorithm, and as you can see, I put the link in there because it basically is easily accessible to you as a resource online, because I'm sure it's going to be hard to absorb all of this today. But basically what they've provided for us is a way to work through what our treatment, our drug selection should be. So in a patient who is DMARD naive, first time they're going on definitive therapy in early rheumatoid, the drug of choice is going to be a monotherapy, and usually it's going to be methotrexate. If they don't settle, then you may have to reclassify them as moderate disease. And then what you would do is then decide whether you combine with another DMARD or add on a TNF, and it basically walks us through. Likewise, for established disease, it's the same algorithm, the start of the algorithm is the same, and then you go on to decide whether you change mechanism of biologic, etc. So it'd be good to have a look at that. Just wanted to spend a couple minutes pointing out the same disease activity measures that we mentioned earlier on when we're talking about treat to target. And there's 6 of them that have been recommended by the ACR. And basically they're not partial to any, they just say choose a tool. I think most persons, however, in clinical practice use DAS or RAPID-3. And DAS is also seen quite often in our studies. If we look at the breakdown, DAS, it includes a tender joint count, a swollen joint count, a patient global assessment, and an ESR. And all of these disease activity measures provide for us a composite score and a scoring sheet that tells us when our patient is in remission, when they have low disease activity, moderate activity, and high activity. And so it helps to gauge us in knowing whether or not we need to change therapy or change course. RAPID-3 is actually a patient-based evaluation. It's part of the multi-dimensional health assessment questionnaire. And the patient actually sits in your waiting area and fills this out, and then you on the right side would calculate logarithmic conversion. And this is actually what I grew up on in fellowship and into practice. And it's useful because it's not as time consuming, but it does have its limitations. For example, if you have a patient who also has fibromyalgia, you'll find that their scores continue to be quite high, whereas you can clearly see that they are clinically improving. So in summary, I'd just like to close by pointing out, highlighting, the progressive course of RA can be mitigated by appropriate treatment at an early stage. Development of new criteria has allowed us to classify our patients early and initiate care quickly. And this initiation of new treatments has also helped in allowing us to achieve our goal of remission. Early treatment, always remember, is cost effective. We need a multidisciplinary approach where the GPs are key. You are the first point of care. You are very much the advocate of the patient. The patients have long-term relationships with you before they come to us. And I'd just like to close by pointing out that CAR is in the process of trying to see how they can support territories that don't have rheumatologists. And there have been a number of ideas. There is a thought of having rheumatologists from islands that have rheumatologists to travel, or the possibility of using telemedicine as a way to reach our patients. And another interesting thing is that we do have some territories that have insurance boards that will support the cost of patients coming to territories that have rheumatologists. So stay tuned. We look forward to how we can help our patients in the Caribbean. Thank you.
And management issues, and then I'm going to answer some additional questions that were actually sent to me. So for this talk, I'm really focusing on systemic lupus. Of course, you know, some patients just have the skin rash, discoid lupus, and some people have a transient illness, drug-induced lupus, which once the drug is withdrawn, it goes away, and it's not much of a problem. Now, SLE has areas of geographic clustering in the African diaspora, and that's why there's so many cases in the Caribbean. So wherever the slaves were moved from West Africa, so from the Senegal River in the north to southern Angola, 3,000-mile stretch, wherever the slaves were deposited, which is the African diaspora, of areas of clustering of SLE. And in black patients, SLE has an earlier onset and much more aggressive disease than, say, Caucasian populations. Lupus predominates in women ages 15 to 44. It's the second most common autoimmune disease in women. Anybody wants to guess what's number one? It's autoimmune thyroid disease. Right. So it's the classic multi-symptom disease, and it has a relapsing and remitting course. And basically, lupus can do anything, but not everything is lupus. And it's an autoimmune disease, so we have autoantibody tests that can assist in supporting our clinical diagnosis of SLE. So it's still very much a clinical diagnosis. Okay, so just in case you're wondering what causes lupus, think of it as a conspiracy. So it's a complex interplay. There's genetics, but genetics only accounts for 18% susceptibility. There are hormonal influences, and there are environmental influences. But we don't know when the conspirators are going to attack, so we never know when it's going to start. And the best way to think of what's the pathophysiology of lupus, the simplest way is just to think of it as a problem of garbage disposal. So apoptosis refers to programmed cell death. So cell dies, we all have a lifespan, and that releases debris, and the debris is a source of autoantigen. So our native immune system wasn't quite aware of, hadn't seen these proteins before. So when the cells decompose and release the debris, our immune system builds antibodies to them, and these form immune complexes which deposit in tissues and sets up inflammation. But what brings a patient to medical attention? And what you see listed on the slide are the most common complaints. So even though lupus can do a lot of weird and wonderful things, you know, probably 80% of the patients are going to come to presentation because of this. Joint pain and swelling. So you must remember, about 80% of lupus patients at some point in their life will have arthritis. So arthritis is the most common manifestation of SLE. So joint pain and swelling, rashes, hair loss, chest pain, oral ulceration, and then there are non-specific things like fatigue and fevers. Now, I'm sure all of you are aware of the American College of Rheumatology diagnostic criteria, and all our medical students memorize it, and all I want to point out with this, because, well, I want to point out two things. One is that it does focus on the more typical complications of SLE, so that's the usefulness of it. And the other important usefulness of it is that if you have 4 or more of these criteria, that signals a definite case of SLE. But you can have clinical lupus, and there are many lupus patients I'm treating who only satisfy or have 2 or 3 criteria, right? But the definite cases are 4 or more, right? And I don't want to spend too much time on this either, but this is the newer classification criteria. It's widely available online and on Rheum.tutor. Did I get that right? Rheumtutor, sorry. And it expands some of the clinical manifestations of lupus that are used for classification of disease. So it just gives you an appreciation for what are the more typical features of SLE. But what I want to tell you is that SLE is a clinical diagnosis, and guidelines help support the clinical diagnosis, but they don't replace your clinical judgment. So I divided the diagnosis of SLE into a very classic clinical presentation, and then a case where the diagnosis takes a bit more work. SLE enters the differential diagnosis, but it's not as clear-cut. So let's see. Oh, so let me go back because I'm not sure I put. So like a classic clinical presentation is one where the patient can actually diagnose themselves, or another lupus patient might bring their neighbor or their sister, as has happened. So if somebody has a classic butterfly rash, pleuritic chest pain, sores in the mouth, there's certain things that are so definite that they're easy to pick up. Something that would be a case where lupus enters a differential diagnosis is if someone had, say, a pericardial effusion, fluid around the heart. Now that can be caused by lupus, it can be caused by underfunctioning of the thyroid gland, it can be seen in renal failure. So you have to really call on your good old clinical skills and pare down to what the diagnosis is. And the simplest part, the most important part of diagnosing SLE is simply thinking of it. So once you have the case, if you never think of it, that's when it's surely going to be missed. But if you have a case and it's not clear what's going on, simply thinking of lupus would allow you to set all the clinical path in motion to lead the diagnosis. The other thing to remember is that a negative anti-nuclear antibody, remember Dr. Linda mentioned the ANA test, that a negative test does not rule out the diagnosis of SLE. And sometimes in the early stages, or when you first see a patient, the ANA test may be negative, but that does not rule out the diagnosis, especially where the clinical suspicion is high. So if a young woman of childbearing age, a 20-year-old woman, has a symmetrical polyarthritis of the small joints of her hands, even if her ANA is negative, she could be lupus in evolution, and you want to watch to see what will happen next. And ANA positivity is not sufficient to diagnose lupus if the clinical picture doesn't fit. So that I read a statistic in the United States, only 15% of people with a positive ANA turn out to have lupus. That is because in the US, ANA tests are done very frequently, right? So it will be done in people with chronic pain and other things that aren't lupus. So it's just to bear in mind that just having a positive test does not mean you have lupus if it doesn't fit. So the commonest reason I get referred a patient that I have to tell them they're perfectly well is if someone has chronic pain from stress and someone does an ANA and it's positive. Now, I just want to show some clinical images so you'll be familiar with some of the more common presentations in Afro-Caribbean people. And so the arthritis of lupus is non-erosive and it's rheumatoid-like. So you really, and sometimes it's subtle. Is this a pointer? Okay, so look at this. The patient complained of joint pain, and this was a subtle fusiform swelling of one joint. But it was enough to let us know that this was not overuse of the hand or stress. It was a disease that we should look out for, and we should watch and see where this is going. And the image on the right is just a lot more evident with swelling of the hands, but clinically it looks like rheumatoid arthritis. So you look to see what else that patient has that would lead you to think that this is lupus versus rheumatoid arthritis. And you would have seen that rheumatoid arthritis tend to affect older patients. So my typical RA patient is over 50, whereas lupus patients are younger. So when I see a symmetrical polyarthritis, once it's a younger patient, I'm on the lookout for SLE. And then there's something called Jacquard's arthropathy, where there's no damage to the joint, it's more of a periarthritis. There's inflammation around the joint that leads to ligament laxity, and the hand looks like a rheumatoid, a hand damaged by rheumatoid arthritis, but all these deformities are reducible. So actually if they make a fist, the hand looks completely normal. And of course the x-ray shows no erosion, so you know it's not RA. And the malar rash, I put 2 slides because in lighter skin patients, it looks like the young lady on the right, it looks erythematous or pink, plaques in the butterfly distribution. And in patients with darker skin, it tends to be a pigmentary disturbance. And the discoid rash, which tends to be scarring, you have to know where to look for it. And the image on the right is a very obvious extensive rash. So the discoid rash in the patient, you always look at the elbow. If the patient doesn't know they have a rash, they may not present with a rash and you have to find it. Always look at the extensor aspect of the elbows and always look at the ear. So that discoid actually means coin. And not all cases are going to be this florid. So it starts as a little circular area. Usually there's hyperpigmentation and a central depressed area, which is either erythematous or hypopigmented. But then it coalesces into these irregular lesions. So you may find a patient that just has a few of these. And then the ear is another common area that the patient may often not be aware of the presence in the ear. And alopecia is very common. Sometimes it's associated with the discoid lesions, in which case it's scarring. And I don't know if you notice on the image on the right, the patient also has a post-auricular node. So lymphadenopathy is very common. And there's a peeking out of a discoid area by the ear. Oral ulcerations are as another typical lupus finding, and the classic oral ulcer in lupus is painless and on the hard palate. So this patient actually did not know she had an oral ulcer. And unlike the oral ulcers, the average aphthous ulcer, which is painful, or an ulcer that you might get in Crohn's disease, that tends to be painful, but the lupus ones, they can be painful, but the classic rash is painless and on the hard palate. So as you actually have to look for it. So imagine the patient, before I showed you with this symmetrical polyarthritis in the hands, imagine on examination we found a discoid lesion in the ear and an oral ulcer. You see, we're on our way to making the diagnosis one visit. Raynaud's is not that common and severe in the Caribbean, obviously, because of our weather. And so except in certain circumstances. So this was in my air-conditioned office. And you can see the blanching. And we had one month years ago, it was cold. Everybody was wearing sweaters. I think it was cold for 1 day. And I saw a patient where the Raynaud's went to the point where there was gangrene at the tip of the finger, right? Now, because it's so warm, how do we elicit a history of Raynaud's? So what I ask my patients is when you're reaching into the refrigerator or the freezer for meat or for something, bursitis is common, so patients present with chest pain. The image on the left shows a patient had pericarditis severe enough to give a pericardial effusion, so the cardiac silhouette was enlarged. You can see that, right? And on the image on the left, the patient had pleurisy bad enough to give pleural effusions, and there's blunting of the costophrenic angle bilaterally. So the history of chest pain is important, and we further question the patient. So with pure pleurisy, the patients have chest pain on inspiration, right? And the other thing I want to point out is that, can I demonstrate that now? Remember, all of this is lung. So we've had patients present with back pain, and it was thought to be spinal pain. But we asked, what is the back pain like? And it hurts to take a deep breath. That's from the lung, right? And remember, thank you. Lung. So one of my patients went with upper abdominal pain and was being investigated for gallstones. I asked her when I went down to the emergency room, what does it feel like? She said, it hurts when I take a deep breath. It was pleurisy. So just remember the lung, God gave us a lot of lung. Now, for pericardial pain, remember the classic thing is it hurts, it's worse when you lean back, and it feels better when you lean forward. So in our history, we try to elicit all of these things. Renal disease, now this is, you don't want your patient, you want to pick up patients before the renal disease becomes symptomatic. Oh, 5 minutes, okay. Okay, even though I did a demonstration, all of them I didn't get Okay. Me today. Okay, so this patient had edema. The skin rash was because she also had villus lupus, but you could ignore that. So, but by the time they get edema, that's significant loss of protein in the urine or significant impairment, and we want patients picked up before that. So renal disease is seen in nearly half of the patients. We want to pick them up when they're early, so we want to pick up proteinuria. So when investigating any patient with suspected lupus, make sure you do a protein, dipstick protein. And in patients who have an established rheumatoid SLE diagnosis, we have them do monthly home monitoring for proteinuria. For the first 3 years, because that's when most patients who are going to develop nephritis will develop nephritis. These are the laboratory investigations. We look for anemia, because lupus patients tend to have an anemia of chronic disease, but they can also have a hemolytic anemia, and then leukopenia, lymphopenia, some thrombocytopenia, so everything low. The ESR may be elevated, and then there are a number of autoantibodies. All I want you to remember is that the ANA is sensitive, so it's present in 95% of lupus patients, but it's not specific, so it's seen in other things like Dr. Dari said. But the anti-double-stranded DNA and the anti-Smith are specific. I always check creatine kinase in suspected lupus because sometimes there's an overlap with myositis, and the fatigue they're having that they think it's because they're ill is really from muscle disease. And urine studies are critical because renal disease is silent until it's severe. Always remember when you're assessing a lupus patient that whatever clinical symptom they have can have a number of causes. So it may be from active disease, it may be from secondary damage from the lupus, maybe a side effect of the therapy, maybe from an intercurrent illness, something transient, or maybe from some other concurrent disease. So lupus patients aren't always easy. They really make you think. So this is an example. So if a lupus patient develops renal impairment, it could be active lupus nephritis. It could be that they had nephritis, now the kidney is scarred and it's damaged. Could be a side effect of therapy, ACE inhibitors or NSAIDs. In Barbados, we have a number of cases of leptospirosis. Because you have lupus doesn't mean you can't get leptospirosis. So when they come in sick, it could be leptospirosis. And then diabetes and hypertension are very common, so and those can also affect the kidney. So we always just have to think and work things out. I won't say too much about the treatment because having a rheumatologist hold your hand through treatment, I think is ideal. And steroids can vary from high to low to high dose. We can also give it by intramuscular injection for minor flares, and very high dose steroids for critically ill patients in hospital. This is a question I got asked and I thought I would interject it here. Special precautions and side effects of chronic steroid use. When starting steroids, I asked patients to modify their diet and take out the refined starches and sugars to reduce the weight gain that they're going to complain about, and to reduce the risk of steroid-induced diabetes. And diet rich in calcium to promote bone health. But then it's our role as doctors to keep the steroid dose as low as possible and for as short a period as possible. And we want the patients to be adherent to reduce the need to keep having flare-ups and keep having to go back on steroids. I'll skip that. Another question I got asked, side effects and precautions of chronic steroid use. We have patients take a vitamin D supplement. What is it? Oh, right. Remember that steroids sometimes can cause damage to the hip, avascular necrosis of the hip. So I tell patients to tell me if they've developed hip pain. because we want patients to go off on crutches and not bear weight on the hip when that starts to happen. Because in developed countries, they can get MRIs quickly and even have an intervention on the hip called core decompression, and we don't have access to those things. So we need, once it's suspected, they may have damage to the hip from steroids, that they go on crutches. And we ask patients, obviously, not to stop steroids abruptly because of the risk of Addison's. One of the key treatments of lupus is the anti-malarials, and you get a baseline eye exam when patients are on that. And we have azathioprine, methotrexate, cyclophosphamide, mycophenolate, mofetil, rituximab for the more severe cases. And this is going to be, patients needing this are going to have a rheumatologist involved in the care to guide this sort of treatment. Just a little on SLE and pregnancy. There is a risk of preterm delivery. Pregnancy risks are highest when the disease is active, so I like patients to be under control for 6 months to 2 years. They never listen to me. And some drugs are safe in pregnancy, so we keep on, especially hydroxychloroquine, but azathioprine is one that's also safe. Prednisone, we don't like to use in pregnancy, but it doesn't reach the fetus. It's denatured in the placenta. There is an increased risk, just a bit about cancer and SLE, because these are questions you may face. There is a risk of lymphoma and CA cervix, and we do advocate our patients get the HPV vaccine. Okay, I was told to address this. How do we know if a lupus patient is flaring or it's something else, like infection? And one of my residents is texting me about a patient in Barbados. So it really comes down to clinical judgment, history and exam. Sometimes I think it's even easier if I tell them, if you think, what would this symptom be due to if it wasn't a lupus patient? Because the fact that it's a lupus patient, people sometimes get all anxious that it might be something wild and wonderful. But just use common history and exam acumen, and look at the clinical features and exclude other plausible causes. In terms of lab tests, for active lupus, a lot of our patients have leukopenia, lymphopenia, so that's a clue, and a normal CRP. So officially, patients with infections tend to run high CRPs. Just a pure lupus flare, the CRP could be normal. And if you see a combination of a high ferritin level and a normal CRP, that would suggest lupus activity is the cause. Now, where you have it, and I don't always have this, a high anti-double-stranded DNA test and low complements suggest active SLE over something else. And that something else is usually infection. But life is not easy, and it's not uncommon for a lupus patient to have active infection and active lupus all at the same time. I just want to skip that because my time is out. Management of fever in lupus, especially those on immunosuppressive meds. This is a question that I got emailed to me. And the aim is early septic screen. So a fever in a lupus patient on immunosuppressive drugs is an emergency. And in all the guidelines for management of infection, no matter, in the early days when I was a resident, currently, in spite of all the developments, the number one thing that makes a difference is early, like within the first hour, early initiation of antibiotics. Hence why it's such an emergency to see these patients. The most common sites of infection, lung, skin, and genitourinary. And then other sites may be involved, but your patient's symptoms like CNS or new heart murmur or joint symptoms may determine where you need to look. And the patient may have a viral illness, but usually in our experience, unless it's severe dengue, the patients with viral illnesses are not that sick. And it's antibiotic coverage while pursuing whatever the infection might be. And all the more potent immunosuppressive medications I mentioned to you, like methotrexate or mycophenolate, mofetil, would have to be held. But steroids can't be discontinued suddenly, and usually they still have to continue on the steroid. I just want to give this quick illustration of this case I call vein to brain. This case is one of my lupus patients in hospital, and she was obtunded, then had seizures, and what you're looking at are micro abscesses in the brain, and it was Staph aureus in her blood culture. But and this looks all complicated, You know what was the site of this? The vein tells you. She had a drip site infection, seeded the blood into the brain. And all that has to be done now is that we're vigilant in all patients about drip sites, and now as part of the ward round checklist, everybody's drip site is examined, not just lupus patients. But this is an example of how something so simple and preventable could lead to something so catastrophic. Somebody asked me about the common causes of pain, and the common causes of pain in lupus is arthritis and avascular necrosis of the hips. For arthritis, is treatment of the underlying disease, and avascular necrosis sometimes needs a surgical intervention. I was asked to say something about narcotics, and we don't often have to use it. We focus on treating what the underlying cause of the pain is rather than just treating the pain. And always remember that stress is a cause of pain, and you don't want somebody who's under stress complaining of pain to be needlessly treated with any therapy that's not directed at stress. So in summary, SLE is a classic multi-symptom disease with certain typical features but potentially diverse manifestation. Observation sometimes require diagnosis sometimes require observation over time. And the Caribbean is an area of clustering of the disease. That's why the disease is kept in mind. Okay, thank you.
Good afternoon, everybody. I am grateful for being here, so thank you to all the CAR team that invited me to speak. I have been tasked with the topic of septic arthritis, which in itself is very challenging to diagnose and to speak on because it is very extensive. But I also have to speak on other rheumatologic emergencies. So I will be quick, but most of my talk will be focused on the former. So my objectives. One is, like I mentioned, I will speak on septic arthritis. I will break it down into 3 different categories, but we'll focus mostly on non-gonococcal septic arthritis. We'll talk about the definition, the predisposing factors, pathogenesis and causative organisms, about how to go about diagnosing it, and ultimately treatment, both pharmacologic and indications for surgical intervention. For other rheumatologic emergencies, I will give a brief synopsis of the symptoms, diagnosis, as well as treatment. So I want to delve right into it with 2 cases, and I'll explain at the end of the cases what we're talking about. A 67-year-old lady, pre-morbidly bedridden due to stroke, was brought in from a nursing home after complaining of left knee pain and swelling for a week. She had no systemic symptoms of fever and no history of trauma. Past medical history significant for diabetes, hypertension, chronic atrial fibrillation, and she's also on long-term steroid therapy for autoimmune hemolytic anemia. On examination, she had a left knee which was swollen and tender, warm, erythematous, extended to mid-thigh, and other systems upon examination was unremarkable. And other causes of joint pain or joint swelling like sickle cell disease, hemarthrosis, neuropathic arthropathy, and malignancy. So what are our treatment choices? There are no randomized controlled trials that show exactly what treatment should be given for septic arthritis, nor are there any randomized controlled trials showing what the duration of treatment should be. However, empiric antibiotic coverage for suspected bacterial arthritis covers the most causative organisms. Gram-positive cocci, we would give vancomycin, gram-negative, ceftriaxone, gram-negative rod, and it goes on. However, I must mention again that for anybody with negative gram stain, we add ceftazidime, 3rd-generation cephalosporin or aminoglycoside to that in order to cover those persons who might be immunocompromised. In terms of duration of antibiotic therapy, in an uncomplicated native joint, meaning a joint that's not prosthetic or without any underlying other type of arthritis, parenteral antibiotics are given for at least 2 weeks. For patients who are immunocompromised, parenteral therapy for 2 to 4 weeks, followed by oral therapy for 4 to 8 weeks are standard. And for prosthetic joints, it's typically a protracted course because mostly the joint most likely has to be removed, and then there might be use of antibiotic impregnated beads in the joint or cement, And that time course can be from months to more than a year. And the choice of oral therapy for subsequent therapy depends upon, of course, the pathogen. Finally, I can't go through this because of the constraints of time, but antimicrobial therapy for septic arthritis, again, is the list for when you have identified a species. Then, of course, you hone your antibiotics to what the specific species is to get better coverage based on the sensitivities. And finally, treatment. Joint decompression with repeated needle aspiration is a must, and it's not only done to get rid of the infection, but it's also done to help relieve pain and to help support movement in the joint. Typically after 3 to 5 subsequent days of repeated joint infections, if there's still inadequate drainage, then arthroscopic drainage and lavage is indicated. And this is just a study showing that. In terms of open surgical drainage, that typically is done for the hip joint, and it can be done for any joint, but again, for any joint in which there's inadequate drainage, it's done. Exchange arthroplasty, like I was mentioning before, in infected joints is important. And what is important as an integrated part or giving holistic care for the patient is physical therapy, and that is waiting until all the signs of infection in the joint has resolved, and then rapid mobilization so the patient can gain function in the joint. And so in summary, septic arthritis should be a key consideration in adults presenting with any acute monoarticular arthritis. Non-gonococcal pathogens, in particular staph, is the main causative organism. You have to have a high index of suspicion and select the appropriate diagnostic test. Well, the main thing is you need to tap the joint, and the therapeutic options, like I listed before, to cover the empiric antibiotic coverage to cover what are the most likely causative organisms. And finally, an integrative approach to treatment with early orthopedic consultants and physical therapy for rehabilitation is a must. Now, I had 5 minutes, but I have couple more things to mention. One is, I have not expanded, and I will not expand because I have tables that you can get, but the emergencies in rheumatic diseases can be many and diverse. And by looking at, for example, the different diseases, there can be many emergencies in each case. For example, what we just mentioned, particularly affecting patients with rheumatoid arthritis, but also atlantoaxial instability, ankylosing spondylitis, spinal fractures, atlantoaxial subluxation, for systemic sclerosis, I know we're familiar with renal crisis, for SLE, alveolar hemorrhage, catastrophic antiphospholipid syndrome, in which the patient has there's a vascular occlusion, in more than 3 organs, and as well as pericardial tamponade, Zika syndrome, hypokalemic paralysis, temporal arteritis, vertebrobascular insufficiency, and GPA subglottic stenosis. And these are some tables that highlight some of the clinical features, the diagnosis, and some of the treatment of all of these cases. And so with that, I will conclude. Any questions? And this is just a picture saying hello from Nassau, Bahamas.
Excellent presentation. Welcome the question.
I'd like to thank Dr. King and the CAR Association for putting on a wonderful symposium, and thanks for inviting me to speak to you this afternoon. So I'm going to talk about gout. For this talk, these are my disclosures. I've been involved in some prior clinical trials of gout. So I'd like to talk very briefly about the epidemiology of gout and risk factors. We'll talk about the diagnosis and end with the treatment. So gout is associated with hyperuricemia. And hyperuricemia occurs when the solubility of uric acid in serum is exceeded. And the solubility of uric acid is at 6.8 milligrams per deciliter or 420 micromoles per liter. Many patients who have elevated serum uric acid levels are asymptomatic. That is, they have no history of acute gout attacks. There's no evidence of chronic tophi that have developed because of chronic hyperuricemia, and there's no history of renal calculi. And those patients are referred to as asymptomatic hyperuricemia. It remains debatable in the literature whether those patients are at increased risk for cardiovascular disease and renal disease, but treating those patients has not been shown to lower the risk of those cardiovascular renal diseases at this point, and so it's not recommended that they have treatment. Now, gout is a clinical syndrome where there is an inflammatory arthritis or periarthritis that develops in response to the deposition of monosodium urate crystals that have deposited in tissues and periarticular structures because of chronic hyperuricemia. At times, these crystals may form masses under the skin, which we refer to as tophi. So gout is a common arthritis. We've heard earlier today that rheumatoid arthritis is the most common autoimmune inflammatory arthritis, but worldwide, gout is the most common inflammatory arthritis. The prevalence has been increasing. There is very little data from the English-speaking Caribbean as to the prevalence of this disease, but in a study from the University of the West Indies, very small percentage, less than 1% of cases, both in the outpatient and inpatient clinics, were secondary to gout. And however, gout is increasing rapidly in frequency, and there are a number of reasons for this. The contributing factors include that people are living longer, and there's increased hypertension. And we know gout is associated with hypertension and the treatments used for hypertension, primarily hydrochlorothiazide and other diuretics. But other factors are responsible for this increased incidence of gout. Obesity, metabolic syndrome, renal disease, and the use of aspirin for prophylaxis against cardiovascular disease. Aspirin inhibits the kidneys from excreting uric acid, and that results in hyperuricemia. Additionally, we are doing more transplantation around the world, primarily renal transplants, and many of those patients are on cyclosporin, and that agent as well is associated with hyperuricemia. So patients with gout present with acute attacks, and typically we talk about podagra, which is the acute presentation of pain, erythema, and swelling in the first MTP that we can see here. Now in our darker complected patients, you don't see the erythema, but you can see hyperpigmentation at the site. And so that's something to look out for. Now, this first MTP is a common site of degenerative joint disease, or OA. So pain at that first MTP does not mean a diagnosis of gout. And we need to distinguish and be aware of what the clinical presentation of gout. So somebody who presents with gout, usually the attacks occur overnight and they are hyperacute in onset. That is, within several hours, the patient who was previously well without any pain or symptoms in a joint suddenly develops pain and swelling in that joint. The pain and swelling is of such severity that they lose function. That is, they don't want to put their sock on, they don't want a sheet touching that foot, and they walk with a limp. And that's a typical history that you're looking for the onset of gout. These attacks are self-limiting, so if you do not treat the attack, they resolve completely over the next several days. However, with gout, they tend to be recurrent. Certainly with treatment, you can shorten the duration of these acute attacks. At the other spectrum of the disease are patients who have chronic tophaceous gout, where over several years of hyperuricemia, you have deposition of uric acid crystals in these large masses that can form in and around joints. Typically, they are seen over the olecranon and bursa. They may be seen classically over the tragus of the ear, other extensor surfaces such as over the patella tendons, the Achilles tendons, and the first MTP, as well as over the fingers in patients. And the spectrum of gout between that is quite extensive. So the typical natural history is that you have a patient with asymptomatic hyperuricemia. About 12 to 20% of patients with asymptomatic hyperuricemia will develop a gout attack over over their course of their lifetime. The attacks are initially infrequent and may occur a couple times per year. If we fail to treat these attacks, the attacks occur more frequently and patients may start having several attacks per year and eventually having attacks every month. The attacks that were initially lasting a few days may now start to last longer, lasting up to 1 to 2 weeks, but usually resolving by then. But however, they may go on to the state of chronic gouty arthritis, where there is chronic inflammation of that joint, and they'll have superimposed acute attacks on top of that. So we talked about the patient with acute gout developing an acutely swollen joint that resolves completely. When a patient has chronic gouty arthritis, the attack persists, so they may have this acute swelling and pain, but that may be resolved, but it doesn't resolve completely. They continue to have mild degree of inflammation, pain, and loss of function at that joint because of that. And we certainly don't want patients to reach that stage. We should be addressing these patients way before that at this stage here to prevent them from developing a chronic gouty arthritis where they'll have significant pain and disability and loss of function at that stage of the disease. Now, the people who get gout, we see it more commonly in males. You do see it in women, but typically in postmenopausal, after menopause, because estrogen is uricosuric. Estrogen seems to be able to increase uric acid excretion from the kidneys. We see it as people get older. It's described in a number of ethnic minorities across the world. So in the States, you see it more commonly in African Americans. You also see it more commonly in Filipino Americans. They have a particularly high incidence of gout. In New Zealand, you see it more commonly in the native Maori Indians or the Maori population compared to Europeans in that area of the world. We talked about obesity and metabolic syndrome. With metabolic syndrome, you have a number of factors and cytokines that inhibit uric acid excretion, and those patients have hyperuricemia as well. Diet is a factor in gout, and it's noted that people who have diets high in animal proteins, particularly red meat, have a higher risk of developing gout. Alcohol is a major risk factor for gout. Alcohol increases both the production of uric acid as well as inhibits the excretion of uric acid, leading to hyperuricemia. In the US, high fructose corn syrup is added to a lot of condiments, sweeteners, soft drinks, bottled juices, and high fructose corn syrup as well affects ATP metabolism, results in high levels of uric acid as well, and this is thought to be a major risk factor for gout and responsible for its increased incidence as well. If the kidneys are not working properly, that leads to hyperuricemia. There are another number of medications. We mentioned diuretics, but niacin as well for hypercholesterolemia, low-dose aspirin also increase the risk of gout. And these all lead to hyperuricemia and increase the risk of a patient developing gout. However, if a patient has already had gout attacks, there are a few things that can cause them to precipitate an acute gout attack. If they go and have a diet that's high in animal protein, so we'd see patients going on a binge or at a family barbecue where they eat a lot, that may cause an acute gout attack. Patients who drink a lot of alcohol. It's not uncommon for us to be called to the surgical ward to treat somebody who has an acute gout attack. And this is because they are fasting, they're breaking down a lot of proteins, endogenous proteins, which leads to hyperuricemia and gout attacks as well. And of course, the initiation of low-dose aspirin for cardiovascular disease prevention may result in acute gout flares as well. In our part of the world, sickle cell anemia is a major risk factor for gout. Patients with sickle cell anemia, as you know, have an increased urate load because of the ineffective erythropoiesis, which leads to increased uric acid levels, as well as chronic kidney disease, where they have difficulty concentrating the urine and failure to excrete uric acid. All that leads to hyperuricemia and the development of gout. There are chronic changes that may be seen as a result of sickle cell disease may also be seen in these patients, and you have to try and differentiate patients with acute painful crises as from acute gout attacks as well. So the diagnosis of gout is a clinical diagnosis. Ideally, we like to be able to aspirate the joint and show that we have demonstrated that the patient has monosodium urate crystals in the synovial fluid to confirm the diagnosis. But the majority of patients that I see, that has not been done because we don't see them during their acute gout flare, and we make a clinical diagnosis. And that clinical diagnosis is based on the presence of, on their history. They report that it's an acute onset of pain that's been recurrent, and these attacks are short-lived. And if we're getting that history and they have hyperuricemia in the serum, we will make a diagnosis of gout. If they present to us acutely and they have a hot, warm, swollen knee, ankle, or wrist, we're able to aspirate the joint and demonstrate the presence of monosodium urate crystals under polarized microscopy. If we're able to do that, it gives us confirmation that they have gout. There are radiographic features that we may also look for in patients with gout. The advantage of aspirating the joint is we can rule out some of the other causes of arthritis that may mimic gout. And these include septic arthritis, as we heard from earlier today from Dr. Roll, and that's the most important thing we want to rule out, because missing a diagnosis or a delayed diagnosis of septic arthritis can have serious consequences, permanent destruction of the joint, or even death from septicemia if it's not picked up and treated quickly. Pseudo-gout is very similar to gout, but it's caused by pseudo-gout crystals, which are CPPD, calcium pyrophosphate crystals. The attacks are very similar and indistinguishable clinically from gout. And those are some of the major things in the differential diagnosis of somebody presenting with acute joint pain. Patients who've had long-standing gout for several years may have a chronic arthritis that is very similar to rheumatoid arthritis, and we have to be able to make the distinction between those. And sometimes it is difficult, even looking at radiographs, to distinguish between the two. However, there are some classic radiographic features that we look for, and we always look for elevated serum uric acid. You can have gout in patients who have normal serum uric acid levels, and this could be that they've previously had higher serum uric acid levels before that led to deposition of crystals inside the joint that have precipitated a gout flare. But typically patients have hyperuricemia with uric acid levels greater than 6.8 for them to have developed gout. There are some newer techniques that have been used. Earlier this week, we had a demonstration of the use of musculoskeletal ultrasound to diagnose gout, and we're looking for this double contour sign. But in patients with asymptomatic hyperuricemia, sometimes there's a newer technique called dual energy X-ray absorptiometry, where you can see these, dual energy CT scans, where you can see deposition of crystals that signify gout. So we talked about the diagnosis, so we use the criteria to make that diagnosis. The ACR has developed criteria where you can add up points, and this, although it's used for research studies, can aid us in making the diagnosis as well. And there are a couple other techniques that can be used, other tools available online. We're a little short of time, so I'm going to skip through this. So the management of gout is divided into the management of acute gout attacks, the prevention of future acute gout attacks, and the management of not only chronic tophaceous gout, but chronic gouty arthritis. So for the acute attacks, you want a potent non-steroidal that's used just during the attack. The patient should have this at home to take as soon as the attack begins. Alternatives include using colchicine at a dose of 1.2 milligrams, followed by 0.6 milligrams an hour later. And this may be continued 0.6 twice daily for 2 to 3 days. Patients who may have contraindications to these, you can use systemic steroids. Usually we'll start with prednisone at 30 to 40 milligrams, and that can be continued usually for up to 5 days. Very rarely you need to go as long as 10 days to treat the acute gout attacks. So if you have a patient who has gout, knows when their gout attacks are starting, you want to provide them with this therapy so they can take that at home. So in terms of lowering uric acid, you recommend diet, weight loss, abstain from alcohol, but there's some drugs that we can use. In terms of the lifestyle measures, we want them to avoid certain things in the food. Alcohol, foods containing high fructose corn syrup, or a lot of organ meats and a lot of red meats. Weight loss has also been shown to help as well. They do need to limit the amount of certain types of red meat that they're taking, canned and bottled fruit juices, sugar as well as alcohol. And you want to encourage them to eat vegetables and low-fat dairy products. Patients who have chronic gouty arthritis, who have tophi, who have frequent acute attacks, more than 2 per year, or chronic kidney disease, or have a history of kidney stones, would be indications for starting urate-lowering therapy. And we want to get them to a uric acid of less than 6. If they've got chronic gouty arthritis or tophi, we want it less than 5. So the reason for going for a treat to target is that if you do get them below 6, you can usually, over time, prevent them from getting acute gout flares, and you can eventually get resolution of the tophi. So we typically will start with allopurinol, and if they've got normal kidney function, we'll start at a dose of 100 milligrams per day, and we'll slowly increase that dose to get their uric acid below 6. When you start urate-lowering therapy, these patients should be advised that they are at increased risk of developing acute gout flares. And so for that reason, we'll put them on prophylactic therapy to prevent the gout attacks. That prophylactic therapy may be colchicine, 0.6 milligrams once daily or twice daily if they've got normal renal function, or we can use a low-dose non-steroidal such as naproxen, 375 milligrams twice daily. And we'll continue that until they've got a low serum uric acid level below 6 and we no longer need to adjust their allopurinol, and then we'll typically continue that for an additional 6 months. There are additional therapies available such as febuxostat. There are uricose uric agents which increase uric acid excretion. We don't use these very often, but they are available. Losartan, a medication for blood pressure, has also been shown to lower serum uric acid levels. And then there's the therapy of pegloticase, which actually helps to break down the uric acid and cause excretion. Patients with gout have a lot of comorbidities that we need to be aware of and monitor the patients for these as well. So in summary, gout is a common acute arthritis. It's becoming increasingly more prevalent in all of our populations, and the treatment should be directed at lowering the serum uric acid level. We want to treat to that target of less than 6. When we initiate urate-lowering therapy, we want to make sure the patient is on prophylactic therapy to prevent them from getting further acute gout flares. Thank you.
Thank you very much, Dr. Stewart. I'm sure we have a lot of questions to you later on. Now we move to our next topic, and that is for Dr. Carmona, and he's going to talk to us about osteoporosis. Dr. Carmona is then to present him, it will take me 2 hours, so I will make it short. He is an associate professor at the Division of Rheumatology, Department of Medicine.
How many of you have patients over 50 in your practices? Okay, right. So then almost all of you have patients with osteoporosis in your practices. Sorry, I thought we were just getting the slides. Okay. All right, so these are my disclosures. I'd like to acknowledge the Osteoporosis and Fracture Prevention Program in Ontario, Canada. I have adapted some of their slides in my presentation. So these are the objectives. I'm going to just review the importance of osteoporosis and fragility fractures, review how to assess a patient for osteoporosis, how to determine fracture risk, and then look at the treatment of osteoporosis. So as you know, osteoporosis is really loss of bone mass. So typically we associate it with female patients, typically after 50, so sort of a post-menopausal problem. But the first point that I want to make here is that actually osteoporosis is also quite common in men as well. Right, so how many of you have seen patients with fragility fractures in your practice? Okay, so some at the back. How about the family docs in the room? Okay, so if you haven't seen patients, probably it's because your patients are probably going to orthopods, right? By the time a patient shows up to the hospital with a fracture, fragility fracture, it's a surgical problem, but that was initially a medical problem. So this is usually how we define a fragility fracture. So it's a fracture that occurs spontaneously or following minor trauma. So if a patient comes in the hospital and they're just fallen from standing height, they've got a fracture, that's a fragility fracture. Or with sort of minor activities, reaching, coughing, patient lifting up a basket of laundry, severe back pain, fracture, that's also a fragility fracture. And these are the common bones that would be involved. So proximal humerus, ribs, pelvis, hip fractures, distal radius, so we see this a fair bit, and spine fractures. The second important point I want to make here about spine fractures is that this is often silent. So a patient can have some severe back pain, maybe for a couple of weeks, gradually resolves, never present to their physician, but they may have sustained a vertebral compression fracture. And the other thing about osteoporosis in general, forgetting fractures for a moment, is that patients don't feel osteoporosis, right? So they may not present to you with any particular problem. So it's actually a very, very common problem. So this obviously it's Canadian data, right? But this slide just makes a point as to how common osteoporosis is. So if you look at this, so if you combine heart attack, stroke, breast cancer, right? All of that combined, it would not be as much as osteoporotic fractures, right? So it tells you how common of a problem this is. In fact, if you, again, patients over 50, the lifetime risk for any female, any woman over 50, it's about 12% for sustaining a hip fracture. So it's certainly a major problem. Now, what's the big deal, right? I mean, fragility fracture, they may get it repaired, right? What's the big deal about fractures? So it's a significant problem. So if in women with hip fractures, there's significant morbidity, loss of quality of life. About 40% will end up needing assistance to walk. 18%, again, Canadian data, but it tells you that these patients need a lot of support after they've sustained a hip fracture. 18% here in Canada would need long-term care. And the other thing here is that a fracture begets fracture. So if a patient has a fracture, they're quite likely to have another fracture, right? But in this particular study, a patient's presenting with fracture, when they look retrospectively, 40% of these patients have had a prior fracture. So if you look at patients who have hip fractures, within 1 year, about 1/3 of them would have another fracture, so quite high. And by 5 years, this goes up to about 50%. So again, it's a major problem. If you have a patient with a fracture, they're probably high risk of breaking again. And in patients with spine fractures, by 5 years, 20% of them would have had another spine fracture. And the other big problem here is mortality, right? Now, when we think of osteoporosis, we think of fragility fractures, we don't often think of death, right? But these patients have a high risk of dying. So in this particular study here, 1 in 5 patients died, right, falling having a hip fracture at 1 year, right? 20% of them were dead. And of course, there'll be lots of factors that contribute to that: the hospitalization, the surgery, the perioperative risk, venous thromboembolism, and all of these things. This year was actually a prospective study. So another study done in Canada, it recruited about 8,000 patients and followed these patients prospectively. So at the beginning, they didn't necessarily have osteoporosis, but then they followed 8,000 patients to see what happened eventually. And in patients who eventually developed osteoporosis and had a hip fracture, within the first year, they were 3 times as likely to, well, 3 times more likely to die, right? The second year, this sort of settled down. But if you look at vertebral fractures, right, in the first year and the second year, they were 3 to 4 times more likely to die. So again, a significant problem with mortality from fractures. So how do you assess patients for osteoporosis? So I went to UE, right? We focus a lot on clinical examination, clinical skills and so on. In the first world in North America, they focus a lot on investigations. I think it's still important to do a really thorough history, good physical examination, come up with a diagnosis. And if you don't have access to BMD, there's still a lot of information you can pick up clinically. So history, for example, if you have a patient coming in, an older patient over 50, always ask about whether they've had any fractures. And if they've had a fragility fracture as I defined there, then whether you have a BMD or not, that patient has osteoporosis. If they've had prolonged steroid use, right, so for whatever condition, prolonged steroid use is defined as more than 7.5 milligrams of prednisone or equivalent for more than 3 months over a year, right, cumulative exposure. If they've got that, they've got a good chance of having osteoporosis. And if the patient tells you that they've lost height, now if it's more than 6 centimeters, they definitely have vertebral compression fractures. Doesn't mean that it's beyond 6 centimeters. If they've got 4 centimeters, 3 centimeters. But if it's 6, you can bet your bottom dollar this patient has vertebral compression fractures. So if you get a patient, for example, presented to the hospital with a vertebral compression fracture or any other fragility fracture, elderly patient, you should consider multiple myeloma, obviously. So you want to check for that. Patient with celiac disease, you want to test for that. And then as mentioned in men, you may want to check for hypergonadism. How many of you have access to BMDs? So I guess that answers the question. So this is in North America, they've got a luxury of having access to all of these things. At the center where I work, we have 5 MRI machines in the city. So stuff like that, BMDs, you have at every hospital. It takes like 2 days to get a bone density. Sometimes I send a patient downstairs and within an hour the result comes back up. So it's very, very quick access. But I'm going to show you that you don't necessarily need to have BMDs to predict fracture risk. But if you do, it really, really helps. So the BMD, what they assess is the lumbar spine and the hip, and it does correlate with fracture risk, which is why it is a valuable tool. Right? So I'm not dismissing it. It is a valuable tool in terms of risk stratifying which patients are high risk of fracture, and therefore which patients you need to treat. So these are, in Canada, these are the indications for doing a baseline bone density test. So all men and women, once they hit 65, they get a BMD. In younger patients, 50 to 64, who has certain risk factors, for example, weight loss, if their parents had hip fractures and so on, you might start screening these patients at an earlier age and not wait for them to hit 65. Obviously, if they've got a fracture, if they use steroids, other medications like aromatase inhibitors using breast cancer, anticonvulsants, androgen deprivation therapy, that would be using prostate cancer, and so on. Patients on drugs like that, those are high risk. So these patients will also get a bone density before they hit 65. And then conditions associated with bone loss. So patients who have rheumatoid arthritis, for example, they've got an increased risk of having osteopenia, osteoporosis, and other conditions, for example, like the malabsorption syndrome, inflammatory bowel disease, and so on. So these people will usually screen at a bit earlier than 65. So if you have access to BMD, this is usually how we measure whether the patient has osteoporosis or not. So we look at T-scores. So if the T-score, and you look at lumbar spine and you look at hip, if the T-score is between -1 and +1, that's considered normal. If it's -1 to -2.5, that's osteopenia, so the bone is slightly thin, quote unquote. And if it's under -2.5, that's osteoporosis. The main problem here, though, is that most patients who have fractures actually fall in normal to osteopenic range, right here, right? And that's because you have more people with osteopenia or with normal bone density than you have with osteoporosis, right? But obviously, if you're under 2.5, you have a higher risk of breaking your bone. And essentially, this is what I just said, right? So 60% of women with fragility fractures, they actually have scores that are not in the osteoporotic range. So how to determine fracture risk? So these tools that I'm going to show here, you can easily find this online. So this here is PARAC. So this is from the Canadian Association of Radiologists and Osteoporosis Canada. So there are three variables that we're looking at here. There's female patients. So there's also a chart like this for men. Femoral neck score, and then age. So for example, if you're a 70-year-old woman with a score of minus 2.5, that puts in the moderate risk category. And the moderate risk there will be that she has a risk between 10 and 20% for having a fracture in the next 10 years. If you're low risk, it's less than 10% in the next 10 years. At high risk, you have a greater than 20% chance of breaking a bone in the next 10 years. So these patients here need treatment. This is the chart for men. So here it's a little bit different in the sense that the curves are a bit flatter. So if you have that a similar 70-year-old man with a score of, let's say, -2, he'll fall into low risk, whereas if you had a female patient, 70 with -2, she'll be moderate, right? The other factors here that come into play is that there are certain things that will push you into higher risk. So for example, if the patient had a fragility fracture, even if they fell in moderate, that will push them into high risk. If they had prior steroid therapy, that will also push them from one category to the other. And then obviously if you came in and you've had a hip fracture, it really doesn't matter too much. You're at high risk of a fracture. Now this is the tool that you would be able to use if you don't have BNP available. So this is FRAX, and it's also available, it's available freely online. And how many of you guys have used this? So, right, people in the back. Yeah, so you can, if you just Google FRAX tool, comes up online, and you can punch in, so the information just like CARAP that I just showed you, and then the additional factors, you punch those in, and you can get a risk prediction. The thing here is that there are models for different countries. There isn't one for the Caribbean, but you could probably use the country that's most reflective of your patient's racial origin, right? And that should give you a fairly accurate prediction as to their risk of fracture. So based on that risk of fracture, then we'll decide on whether the patient needs treatment or not. So if you have a patient who has low risk, they don't need therapy, you can reevaluate them in about 5 years for their bone health, that is. If it's a moderate risk, you'll want to look at other things that will either push you to not treat or push you towards treatment. So if it's they're moderate risk, as I said, I always do lateral thoracic and lumbar spine. If they've got a wedge compression fracture there, then that's high risk. Those patients need treatment. Other things that might push you towards treatment, if they have malabsorption, IBD, if they're on certain culprit drugs and so on, will push you towards treatment. So people at moderate risk, you really have to sort of decide with other factors whether they need treatment or not. And obviously, if you're high risk, you need treatment. So at a minimum, right, so if you have a sort of moderate risk patient, at a minimum, supplementation of calcium, vitamin D. Calcium, 1,000 milligrams is usually recommended. If your patient is having about 3 dairy products, they're probably getting about 500 milligrams there, so you only need one calcium pill, which is about 500 milligrams. And then vitamin D supplementation, 1,000 to 2,000 units daily. Now, we do have drugs that target different points of bone biology. So if I just take you back to the medical school a little bit here, it's something that you'll be quite familiar with in terms of bone biology. So osteoblasts, as you know, lays down new bone. Osteoclasts pick up bone or resolve bone. And then they communicate with each other through rank ligands. So osteoblasts produce rank ligand, and this leads to osteoclast activation that picks up your bone. So there's this cycle going on here. So the drugs that we have, so you guys mentioned that we're using bisphosphonates, for example. These bisphosphonates bind to the hydroxyapatite crystals in bone, and then when the osteoclasts pick up that bone, it essentially leads to osteoclast death. So the cells that are resorbing bone die essentially, and that's how it works. There's also denosumab. So this is a monoclonal antibody that's given subcutaneously every 6 months. And this essentially mops up right ligand. So it's mopping it up and therefore preventing it from activating the osteoclast. So again, every 6 months, it looks to be really, really convenient and highly effective therapy. There's also selective estrogen receptor modulators, so that's raloxifene. And then there's hormone replacement therapy. These you'll use in very niche, very selected patients. So if you have a patient, for example, who has a history of breast cancer, this might be a useful therapy here. If you have a patient who has a lot of perimenopausal symptoms, then hormone replacement therapy would be reasonable there. The thing though is that both of these classes here are associated with venous thromboembolic disease. So you want to generally avoid this, again, unless you have a really select patient that may benefit from it. And then the other one here is PTH analogs. Now you remember from medical school, from basic biology, that parathyroid hormone causes bone resorption, right? But here we have a drug that's actually recombinant PTH that we're giving to patients with severe osteoporosis. And the way it works is that because you're giving it as an injection, so it's actually given as an injection daily for 18 months. And it's every 24 hours when they get this sort of pulse-style dose, that actually sort of acts the opposite way, that just stimulates osteoblasts to create new bone. So this here is the sort of drug that we'll use in patients who have severe osteoporosis, not responding to other drugs, or who are having multiple fractures, and it's highly effective at building back bone. So these are all the drugs I just said, they all work. So these here, I think we've used fairly often in the Caribbean, and they reduce fracture by up to about 60 to 70%. This is the intravenous form of bisphosphonate given as 5 milligrams IV once a year. Teriparatide, so that's a recombinant parathyroid hormone I just spoke about, also quite effective at reducing fracture. And then skip raloxifene, denosumab, as mentioned, twice a year, and about 70% reduction in the risk of fracture. The benefit with these two agents is that they build backbone. So, a couple points here. Drugs don't work if we're not prescribing them. That's pretty obvious. And then the other point here is that drugs don't work if patients don't take them. And the reason I'm saying this is that if you have patients with osteoporosis, or like I tell you, you definitely have patients with osteoporosis, and you're giving them bisphosphonates, if they're using it less than half of the time, there's no benefit, right? So they have to be using it as prescribed. And in terms of safety, the safety of these agents that I've mentioned, it's generally safe. There are some rare side effects which we can certainly discuss in Q&A. And lastly, I'd just like to inform you, so you've heard this mentioned a couple of times. So this is my website, and for those of you who are interested, I have a complete set of videos here teaching musculoskeletal examination. I have also quite a number of the videos teaching MSK injection techniques and so on. And then there's information about other stuff that you'll probably find useful. Thank you.
Back pain. And our objectives really is to make sure we can differentiate between mechanical back pain and inflammatory back pain, to recognize the importance of screening for inflammatory back pain, and to know the most common conditions that can cause this type of pain. We'll also speak about the cardinal features of some of these conditions if time permits. So why is this important? So low back pain, is very common. It's actually a major cause of global disability, and the estimated global prevalences of lower back pain is 9.4%. Interestingly, when I look at the data for the Caribbean, we actually have relatively low prevalence of lower back pain, but this may likely be due to underreporting because we don't really have a lot of statistics on this particular area. In Western Europe and in North America, it has the highest incidence, reaching about 15%. So inflammatory back pain is a proportion of lower back pain. And data suggests that about 14% of patients who have low back pain actually have it due to inflammatory back pain. And therefore it becomes important to recognize what inflammatory back pain is, because given how significant the disability can be with back pain, here is a component that we can actually treat and hence resolve and return these patients to work. So the general recognition for inflammatory back pain, and there are numerous, by the way, classification criteria for inflammatory back pain dating back to the 1970s. And this is the most recent classification criteria by the Acetatus Spondyloarthritis International Society, so ASAS. And they looked at particularly these 5 clinical characteristics that gives a pretty good sensitivity and specificity. The first one is the age of onset of less than 4 years, a slow or insidious onset, improvement with exercise, and no improvement with rest, and last, pain at night, which improves on getting up and moving around. If you would read about this, there are also some other clinical features that are thought not to be as sensitive by ASAS, or which have been used in other classification criteria. And these features include alternating the pain, as well as pain that wakes you specifically in the later half of the night, as well as rapid improvement with NSAIDs. So that brings me to my first case, which is a patient that I've seen recently in clinic, and he was referred to me because of the possibility of gout. So it's a 45-year-old man referred for evaluation of gout. He had chronic back pain or chronic joint pain for several years, which he always attributed to basketball injuries because he played significantly. He's had episodic swelling of the right ankle, the right great toe, and both knees over the last year. He was seen by his PCP, who diagnosed him with gout, and has been treating him intermittently with colchicine and prednisone. However, in the last few months, he's had more frequent episodes and was referred to me for further evaluation. When we dig into his history, he knows that he had a history of back pain in his early 20s, and interestingly, that has sort of resolved over the years, so it's not a major complaint, but he does endure significant stiffness. And for him, it's not a major problem because once he gets moving, that pain improves, and he's still able to play basketball. He also takes ibuprofen on a daily basis. On exam, he has normal nails, a positive bulge sign indicating that he had some small effusions in the both knees, and he also had some tenderness over the right Achilles tendon and right lateral malleolus. He had no rash, no SI joint tenderness, and his x-rays of his knees and feet, it showed mild degenerative changes, and some soft tissue swelling over the right heel, but really nothing of significance. He then had an x-ray of his pelvis done, and what is significant here, if you can recognize this, is the absence of the sacroiliac joints, and that's due to ankylosis. And further x-rays also reveal changes in his spine as well. So inflammatory back pain, the reason why it's important is that it's a leading cause or leading symptom of spondyloarthritis. And this is caused predominantly by annulus fibrosis inflammation, which then leads to scarring and fibrosis, and then to SI joint inflammation, which also leads to that sort of alternating the top pain and lower back pain. The common clinical features of the spondyloarthritis, and recognize that spondyloarthritis refers to what we consider rheumatology, a family of disorders, and they are definitely linked and have overlapping features. And these are some of the more common clinical features that exist in almost all of these conditions. One is the inflammatory back pain, which is characterized by an inflammation of the axial joints, including the sacroiliac joints. They can have an asymmetric inflammatory peripheral oligoarthritis. And when we use the term oligo, as mentioned earlier, we're referring to five or fewer joints. They can have enthesitis, which is inflammation at the insertion of the tendons under the bone. Most commonly, the Achilles tendon is the most common site of this. And it can also have a strong association with the HLA-B27 genetic allele. Other clinical features include uveitis, a skin rash, and colitis. So our 45-year-old gentleman, if you look back at his history, he gives a history of chronic joint pain, and it's not unusual for patients to attribute things to temporal events, even if they're unrelated. And it's possible that he had recurring enthesitis over the years. He's had back pain since his early 20s, so before the age of 40. He endorses sickness in the early morning, which does get better as he moves around. And on examination, he had an enthesopathy or enthesitis, as well as a tendinitis. Additionally, we found out that he was also HLA-B27 positive. So that brings us to the spondyloarthritis and what they are. Now, we classify this family as either as predominantly axial, and the axial conditions are ankylosing spondylitis, or non-radiographic axial spondyloarthritis. That may seem confusing until you understand the definition was based on X-ray changes. So there are some patients who may have very early changes where you don't see the X-ray features, which could be picked up on MRI, and so they call these patients non-radiographic. And for AS, this is a typical picture of someone who's had long-standing untreated disease where they develop loss of the normal lumbar lordosis. Then they can get hip contractures and knee contractures as they try to stand erect. And eventually, they get curvature of the cervical spine where They are unable to look up. And this patient will probably never be able to see the sun unless he's lying on his back on the beach. And then we have the peripheral spondyloarthropathies, and these are the conditions that have significant peripheral involvement. So we'll talk about them. We encountered a few of these earlier. So this is a patient who has psoriatic arthritis, and we recognize that there is dactylitis, which is a sausage-like swelling of the entire digit. They also have some skin changes, and you'll see here they also have nail changes. Just to let you know that, just to sort of reinforce that this is a family of diseases, this is a patient that has keratoderma veneretica. So this is a patient who has reactive arthritis. And no, they have a very similar psoriatic rash on their feet, and if this is biopsy, it would look like psoriasis as well. We have patients who have the IBD-associated arthritis. They can also have axial involvement. And then we have the juvenile idiopathic arthritis that can also be similar. And there are also patients who have undifferentiated disease where they don't quite meet one particular diagnostic category. Once again, to reinforce that they're considered really a family of conditions, and the newest recognition is acute anterior uveitis that was previously described as an association, but now we know it can occur as an entity on its own in association with HLA-B27 as well. So the cardinal features, inflammatory back pain, and this is most common in ankylosing spondylitis, but frequently seen with reactive arthritis, and then less commonly with psoriatic and inflammatory bowel disease. And it's very hard to describe what the true prevalence is. And the reason for this is it all depends on how you define inflammatory back pain. Is it based on radiographic definition? Is it based on a clinical definition? Is it based on some of the other classification criteria, which there are at least 5 of them? HLA-B27 positivity, once again, very common in the prototypic condition ankylosing spondylitis, but can also be seen in reactive arthritis, psoriatic arthritis, and is present in ethically matched controls as well. Note that patients with this disease have a high prevalence of HLA-B27 positivity. If we were to take a population who were all HLA-B27 positive, maybe about 2% of them would actually have these conditions. Spondylitis occurs, and this is a classical X-ray. We call these syndesmophytes. It's very thin, bridging occurring around the annulus fibrosus, and it's due to the invasion of the annulus fibrosus by T cells, and this leads to granulation tissue caused by activated macrophages and fibroblasts, and eventually you have erosions and fibrocartilage being ossifying to form this very thin syndesmophyte. You can also have some periosteal new bone formation, and that can lead to the formation of the bamboo spine as you would have heard before. This patient will have very limited, in fact, they will have no lumbar mobility. Sacroiliitis. This is a picture actually of a normal SI joint. You can see very clean lines on both sides, both inferiorly and anteriorly. And basically, the subchondral region of this joint is invaded by T cells, and you get a formation of granulation tissue. And it tends to occur first on the iliac side. And we have an example of that occurring where you have this sort of sclerosis forming on the iliac portion of the joint, as well as a widening of the SI joint itself. And ultimately, we can have ankylosis where the joint disappears because of fibrosing ankylosis of that area. It's replaced by bone. So enthesitis refers to that inflammation of the tendon insertions, and it's one of the central inflammatory units of spondyloarthritis. And these are the fibrocartilage regions where where the ligaments and the tendons insert. And you can have infiltration of the entheses by T cells, which then leads to granulation process, which leads to bone erosions and new bone formation. And these patients on X-rays will have these sort of bone spurs that you would note, with right leading into the attachment of the tendon to the bone. And here's an example which is generally used to illustrate this happening in patients who have the Achilles tendonitis, where they will have swelling and redness of the Achilles tendon. So uveitis is also a relatively cardinal feature to these conditions. And this is a classic example of a patient who has uveitis with a hypopine. So what are the specific diseases? And we'll go through these very briefly. So ankylosing spondylitis, the prototypic condition. The male to female ratio is like 3 to 10 to 1. Onset age is between 10 and 25 years of age. They can have a peripheral arthritis as well, but of course the most significant involvement is the axial involvement. The Schober's test is a test we use to monitor patients. It's a measurement of the L5 or the dimples of Venus. We go 5 centimeters up and we measure 10 centimeters. We have them bend over and we see how much excursion we have to the lumbar spine based on the change in the skin for the marks that you've made on the spine. And anyone who has an excursion of less than 5 centimeters is considered to have significant reduction in their spinal mobility. Of course, as patients get older and they have degenerative disease, this can also occur. And the extra-articular manifestations include, as we mentioned before, anterior uveitis. These patients can also have psoriasis, and they can also have IBD, and they can have a combination of these conditions. Psoriatic arthritis, we mentioned before that they can have significant nail involvement, and one of the things that can suggest that patients who have psoriasis may develop joint involvement or nail changes. Now, when they looked at patients who had psoriasis, and they also looked to see what clinical, what skin rash was associated with joint involvement, they found that patients who had scalp psoriasis or psoriasis with thick gluteal cleft were more likely to develop joint involvement as well. And this is an example of sausage digit or dactylitis that occurs with psoriasis. There are significant different patterns of psoriatic arthritis. It can vary from a distal arthritis involving just the IP joints. It can be an asymmetric oligoarthritis involving some large joints. They can have an arthritis that's very similar to rheumatoid arthritis, or they can have arthritis mutilans, and we'll have a picture of patient who has that severe arthritis later. So these are some of the early nail changes, severe nail changes, a patient who has joint involvement as well as nail and skin changes. And then the classical picture of a psoriatic erosion, which leads to what we call the pencil and cut deformity in severe cases. And here's a patient who has arthritis mutilans, which where you have significant loss of bone tissue, such that we call it the telescoping joint because of the joint, the skin can literally collapse over the joint. Reactive arthritis, generally triggered by patients who've had a recent infection, leading to then they develop within a few weeks, they may develop joint problems. The course can vary, it can be acute, it can be chronic in nature. Patients also can have similarly a dactylitis, sacroiliitis, and enthesitis. So these patients will typically present with asymmetric oligoarthritis where they have like 1 or 2 swollen joints, like 2 or 3 swollen joints. They can have a certain balanitis, and they can have this sort of severe keratoderma menorrhagica, which as I said is very similar on biopsy to psoriasis. And this is a patient who has reactive arthritis, and once again, we can look and see that it's very similar to a patient who has psoriasis with nail and joint involvement. And the last one is the enteropathic arthritis. Once again, this occurs in about half of patients who have IBD. They can have a peripheral arthritis labeled type 1 or type 2. Type 1 tends to be an oligoarthritis involving large joints, and it can mirror the actual activity of the inflammatory bowel disease. Type 2 is similar to rheumatoid arthritis, so small joint involvement, polyarticular, and occurs independent of the course of IBD. And these patients may additionally have oral ulceration, and they can also have erythema nodosum as well as some other skin lesions. In this case, spondylitis occurs a little bit more rarely, but it can also occur as well. And just one quick slide on the treatment, because there's been an explosion of therapies available for these conditions recently. When it comes to inflammatory back pain and hence to axial involvement, NSAIDs are actually considered a DMARD, and so they're usually the first indicated medication. And patients actually have great relief with this. Not so much for the peripheral arthritis. And additionally, for the peripheral arthritis, we can use the traditional DMARDs, methotrexate, sulfasalazine, some of the other traditional DMARDs. And then the biologic DMARDs are indicated for axial involvement if the patients fail 3 months of therapy with an NSAID. The TNF-alpha inhibitors can be used, and now we have some new medications like interleukin-17A antagonist, secukinumab, ixekizumab, and interleukin-12/23 antagonists as well. And there are some small molecules that are also available for use. So in summary, low back pain is a major cause of disability. Inflammatory back pain that underlying spondyloarthritis represents a proportion of lower back pain that can be treated. IBP is associated with ankylosing spondylitis, psoriatic arthritis, and IBD-related arthritis. And the reason why I underline psoriatic arthritis is that in the Caribbean, we seem to have a significant proportion of patients who have psoriasis. And NSAIDs are considered DMARDs for axial spondyloarthritis. And I'm going to do a quick case presentation because it's always important to present the cases that could be differential. This is a 47-year-old African-American man. He's obese with diabetes, hypertension. He's had progressive back pain for 10 years. His back pain and stiffness lasts for the entire day. He has no radiation, no relief of over-the-counter medications or prescribed NSAIDs, and he's currently on narcotics. And he also knows intermittent knee pain without swelling, no fever, no rash, no systemic features. This is him, and in this picture, he's actually trying to stand upright, and he's unable to. And we try to get him to do what we call the occiput to wall test, where we have a patient stand against the wall or a straight surface and reach their head and sort of stand with their chin parallel to the floor to see if their occiput or the back of their head can touch the wall. And we measure the distance between the occiput and the wall, or the tragus and the wall. And this is a way to sort of monitor these patients over time as well, to see if that distance increases. And he's unable to do it. But here's a picture of his spine. And if you would note, he has significant osteophyte formation. They're large and they're bulky, and not those very nice, fine synthetic phytes that we showed you before. And he also has marked osteophytes if you look at the lateral view as well. And when you do x-rays, you're going to find he has these sort of large, bulky osteophytes, not only there, but at the other points of tendon insertion. And this is a patient who has, any guesses? So he has DISH. This is a patient who has diffuse idiopathic skeletal hyperostosis. It's a condition that's non-inflammatory, which we're not able to treat except to treat the pain, and where the immunosuppressive therapy would not be indicated. And probably more commonly seen because these are the obese patients who have metabolic syndrome who will come with back pain at a young age. Thank you.
Thank you, Dr. Duell.
With long-standing hypertension and diabetes presented to the chiropractic clinic complaining of right hip pain of 3 days duration. Sorry, any chiropractor might be here. No preceding history of trauma, no other articular complaints. Physical exam, stiff and painful right hip, vitals and other organ systems were all unremarkable. Initial AP pelvis x-ray taken on that date was normal. A diagnosis of hip sprain, was given, and she was treated conservatively for 7 weeks with rest, NSAIDs, and electrotherapy. Her condition failed to improve with this treatment and deteriorated further. Arthritis that we've already expanded on, and other causes of joint pain or joint swelling like sickle cell disease, hemarthrosis, neuropathic arthropathy, and malignancy. So what are our treatment choices? There are no randomized controlled trials that show exactly what treatment should be given for septic arthritis, nor are there any randomized control trials showing what the duration of treatment should be. However, empiric antibiotic coverage for suspected bacterial arthritis covers the most causative organisms: gram-positive cocci, we would give vancomycin, gram-negative, ceftriaxone, gram-negative broad, and it goes on. However, I must mention again that for anybody with negative gram stain, we add ceftazidime, third generation cephalosporin or aminoglycoside to that in order to cover those persons who might be immunocompromised. In terms of duration of antibiotic therapy, in an uncomplicated native joint, meaning a joint that is not prosthetic or without any underlying other type of arthritis, parenteral antibiotics are given for at least 2 weeks. The patients who are immunocompromised, parenteral therapy for 2 to 4 weeks, followed by oral therapy for 4 to 8 weeks are standard. And for prosthetic joints, it's typically a protracted course because mostly the joint most likely has to be removed, and then there might be use of antibiotic impregnated beads in the joint or cement, and that time course can be from months to more than a year. And the choice of oral therapy for subsequent therapy depends upon, of course, the pathogen. Finally, I can't go through this because of the constraints of time, but antimicrobial therapy for septic arthritis, again, is the list for when you have identified a species. Then, of course, you hone your antibiotics to what the specific species is to get better coverage based on the sensitivities. And finally, treatment. Joint decompression with repeated needle aspiration is a must, and it's not only done to get rid of the infection, but it's also done to help relieve pain and to help support movement in the joint. Typically after 3 to 5 subsequent days of repeated joint infections, if there's still inadequate drainage, then arthroscopic drainage and lavage is indicated. And this is just a study showing that. In terms of open surgical drainage, that typically is done for the hip joint, and it can be done for any joint, but again, for any joint in which there's inadequate drainage, it's done. Exchange arthroplasty, like I was mentioning before, in infected joints is important. And what is important as an integrative part or giving holistic care for the patient is physical therapy, and that is waiting until all the signs of infection in the joint has resolved, and then rapid mobilization so the patient can gain function in the joint. And so in summary, septic arthritis should be a key consideration in adults presenting with any acute monoarticular arthritis. Non-gonococcal pathogens, in particular staph, is the main causative organism. You have to have a high index of suspicion and select the appropriate diagnostic test. Well, the main thing is you need to tap the joint, and the therapeutic options like I listed before to cover the empiric antibiotic coverage to cover what are the most likely causative organisms. And finally, an integrative approach to treatment with early orthopedic consultants and physical therapy for rehabilitation is a must. Now, I had 5 minutes, but I have couple more things to mention. One is, I have not expanded, and I will not expand because I have tables that you can get, but the emergencies in rheumatic diseases can be many and diverse. And by looking at, for example, the different diseases, there can be many emergencies in each case. For example, what we just mentioned, particularly affecting patients with rheumatoid arthritis, but also atlantoaxial instability, ankylosing spondylitis, spinal fractures, atlantoaxial subluxation. For systemic sclerosis, I know we're familiar with renal crisis. For SLE, alveolar hemorrhage, catastrophic antiphospholipid syndrome, in which the patient has there's a vascular occlusion, in more than 3 organs, and as well as pericardial tamponade, Zika syndrome, hypokalemic paralysis, temporal arteritis, vertebrovascular insufficiency, and GPA subglottic stenosis. And these are some tables that highlight some of the clinical features, the diagnosis, and some of the treatment of all of these cases. And so with that, I will conclude. Any questions? And this is just a picture saying hello from Nassau, Bahamas.
Excellent presentation.